الله الرحمن الرحيم. أولا شكرا للدكتور أسامة وشكرا على حسن الضيافة والمؤتمر الجميل. يسعدني ويشرفني إن أنا أقدم الدكتورة رشا طريف. اتكلمنا عن Pitfalls in Diagnosis and Management of Short Stature. نبذة كده عن الدكتورة رشا. Professor of Pediatric Endocrinology عين شمس University, Deputy Chair of Education and Training Committee of European Society for Pediatric Endocrinology, Vice President of Arab Society for Pediatric Endocrinology and Diabetes. اتفضلي يا دكتورة رشا.
بسم الله الرحمن الرحيم. بشكر حضرتك على التقديم الجميل. بشكر الأخ والصديق العزيز الأستاذ الدكتور أسامة عرفة على دعوتي. سعيدة جدا بوجودي مع حضراتكم، والأخت العزيزة حبيبتي الأستاذة الدكتورة سونيا الشرقاوي، حبايب قلبي يعني هما الاثنين. دي تاني مرة ليا معاكم وإن شاء الله يعني على طول بإذن الله. اتشرفت جدا بوجودي مع حضراتكم النهاردة. كتير قوي كنت بتكلم عن الشورت ستاتشر، إيه اللي المفروض نعمله. لا، النهاردة على سبيل التغيير عايزين نقول إيه اللي المفروض ما نعملوش، إيه هي الغلطات اللي بنقع فيها وإحنا بنعمل diagnosis and treatment of short stature، اللي هي ال pitfalls in diagnosis and treatment of short stature. My outlines are the definition of short stature, the pitfalls in the diagnosis and treatment, and finally I will end by case scenarios. وعايزة حضراتكم تساعدوني فيها جدا ونبقى interactive. إيه الغلطات اللي ممكن يكون الدكتور عملها عشان ما نعملهاش. Definitions of short stature is height below -2 standard deviation for age and sex, or height below 3rd percentile for age and sex, height more than 2 standard deviation below mid-parental height, that is short for parents, or growth velocity below -2 or 25th percentile over 6 to 12 months, and finally height deceleration crossing 2 major percentile lines. So there are a lot of definitions for short stature. This is the classification of European Society for Pediatric Endocrinology for short stature. It's either due to normal variants or pathological causes. The normal variants are familial short stature and constitutional delay in growth and puberty. Pathological causes are due to either primary, secondary growth failure, or idiopathic short stature. The primary growth failure is due to infants born small for gestational age, skeletal dysplasias, some syndromes like Turner and Noonan syndrome. The secondary growth failure is due to chronic systemic illness, whatever the cause, chronic undernutrition, endocrinal causes, metabolic disorders, psychosocial dwarfism, and drugs. On top of the list, we have corticosteroids. And please remember that the normal variants are much more common, while the pathological causes are less common. So we should always exclude the normal variants first before jumping to diagnosis of pathological causes. There are different hormones affecting growth. First, during intrauterine period, taking the upper hand, we have insulin growth factors and insulin. During infancy, nutrition is the most important, breastfeeding and then weaning later on. In childhood, we have growth hormone on top of the list, insulin growth factor 1, thyroid hormone, and last is the insulin. And finally, in adolescence, we need a synergistic effect of sex steroid and growth hormones working together to achieve the growth spurt. So remember that different hormones affect growth in different age group. According to each period, hormone will take the upper hand. Now, how to think about a case of short stature? Diagnosis of short stature simply needs careful history, examination, oxological assessment, pubertal assessment if the child is above the age of 10, and investigation. So we need to set a general plan for diagnosing short stature for proper awareness of the cause of growth failure, upon which the treatment will depend. The clinical assessment starts by history, verifying the age of the child, perinatal history, any chronic illness or drug intake, the school performance, psychological status and family history, the heights of the parents, and the onset of puberty of the parents. Oxological assessment, we measure height, weight, calculate the growth velocity, upper to lower segment ratio to exclude disproportionate causes, and it's important to calculate the mid-parental height for genetic causes. And don't forget pubertal assessment if the child is above the age of 10. And then we have investigations. First, we start by the baseline investigations, CBC, ESR, liver, kidney functions, calcium, phosphorus, alkaline phosphatase, urine and stool. Don't forget to do celiac screening, even if the child does not have any symptoms, because we have asymptomatic or silent celiac presenting with short stature only. And finally, do karyotype for all short girls, even if she's not dysmorphic. If all of these are normal, we shift to endocrine assessment by doing thyroid functions, growth hormone provocation tests, IGF-1, IGF binding protein, and if you are suspecting Cushing disease, we do cortisol and ACTH. Of course, bone age is very important, and do CT and MRI, sella turcica, if the child has got multiple pituitary hormone deficiency to exclude tumors. Please remember that growth hormone secretion occurs in a pulsatile manner, as you see, and the peak is achieved during sleep. So proper sleep is very important, and that's why we cannot rely on random growth hormone sampling. We must do growth hormone stimulation test. I think this is the most important slide here. What are the pitfalls that we can do when diagnosing short stature? First of all, please remember, avoid measuring basal growth hormone. It's of no value because it's pulsatile. We need 2 growth hormone stimulation tests to diagnose growth hormone deficiency, and the cutoff is 7 nanograms per ml. Thyroid functions should be done before doing growth hormone stimulation test, because if the thyroid function is affected, the growth hormone will give a false positive result. Karyotype should be done to any short girl, even if she's not dysmorphic. Bone age does not indicate a definite diagnosis, and a normal bone age excludes endocrinal disease. MRI sella turcica should be done if you have more than 1 pituitary hormone deficiency to exclude panhypopituitarism or tumor. And remember to exclude normal variants and chronic illness before jumping to endocrinal disease. So please remember these slides, because in the case scenarios, we will put mistakes based on this slide. I think it's very important to watch your step when dealing with cases of short stature and to avoid the pitfall for proper diagnosis and management. Of course, the treatment of short stature differs according to the cause. And this brings me to a very important question. Is growth hormone therapy approved for any child with short stature? And here, the answer is a very big no. We do not give growth hormone for any short child. This is the list of growth hormone approved indications, starting by pediatric growth hormone deficiency in 1985, adult growth hormone deficiency, ending by Noonan syndrome in 2007. And this is another long list of non-FDA approved indications where growth hormone could be used, but it's not approved. And some of them are unhealthy and prohibited, like using growth hormone in the gym and for sports and things like that. And here are some tips to remember when giving growth hormone. You should start treatment as early as possible once diagnosis is established and growth hormone indicated. Daily subcutaneous injection is very important at bedtime. Compliance is very important. Larger doses are needed at the time of puberty. Doses differ according to different indications, and larger doses are needed for Turner, Noonan, and small for gestational age. So when to stop growth hormone? In the past, there were criteria to stop growth hormone, like epiphyseal closure, attaining the target height, or no further response. Recently, in permanent causes, patients continue on metabolic doses for life. And when you ask me why, growth hormone, this is why. Growth hormone is not only important for height, it has got a lot of metabolic and important aspects to deal with other than the growth. Patients with persistent untreated growth hormone deficiency will have reduced lean body mass, central adiposity, insulin resistance, dyslipidemia, low IGF-1 and bone mineral density, causing endothelial dysfunction, ending up by atherosclerosis, and increased risk of cardiovascular disease. And this decreases the quality of life and psychological well-being of those children which are adults later on. And that's why those who have growth hormone deficiency should continue on growth hormone on metabolic doses throughout their life. And this is what's happening in Europe and in USA, but this is not the case, of course, here. So this was the very fast review part, and now let's go to the case scenarios based on what we said. And I'll just ask you one question for every case in diagnosis and treatment. What are the pitfalls? And let's make it interactive. Please help me in that. The first boy is a 10-year-old boy. His parents think that he's shorter than his peers. His BMI is normal. His height is -1 standard deviation. His mid-parental height is -0.5. His growth velocity in the last year, 6.5 centimeters per year. Normally, growth velocity is 4.5 centimeters per year. Perinatal history, IQ, general health, puberty, everything is normal. This is his chart. If you look at his chart, he is in the range of -1 from the beginning till the time we saw him. Now, let's answer the question. Is the child really short or not? No. The definition is -2 standard deviation and the child is -1. I will not bother that his parents think that he is short, and this happens a lot. Okay. Does he fall within his parental height range? Remember, we said it is allowed to have 2 standard deviation difference between the parents. So, is he falling? He is falling -1 when we subtract it from -0.5. There is only 0.5 SD difference. This is normal. So, he is falling within his parental height range. Is his growth velocity appropriate? Yes. The normal is 4.5 centimeters and he brings 6.5. He's growing okay. Does he need to be fully investigated? Shall we do all the tests for him? No. Okay. Parents sought medical advice of a general pediatrician. He decided to fully investigate the child as a case of short stature. Do you think his pediatrician took the correct decision? Is he short? No. Okay, and this is what the pediatrician found. He found microcytic hyperchromic anemia, thyroid normal, the basal growth hormone was low, celiac screening negative, bone age 9.7 and the child is 10. MRI cella turcica was normal, and unfortunately, the doctor diagnosed him as a case of growth hormone deficiency. Let me ask you, does he really have growth hormone deficiency, and why? No, we cannot rely on the basal, so he doesn't have. Does he have delayed bone age? No, because we allow 1 year difference between the age and the bone age, so he is normal. Was MRI cella turcica indicated in such a boy? No, the doctor over-investigated him. Does he need growth hormone therapy? No. Very good. So the pitfalls in that child are, the child is not short, -1 is not short. His height is falling within his parental height range, -0.5. Full investigations were not needed from the beginning. Basal growth hormone is not reliable in diagnosis of growth hormone deficiency. The bone age is not delayed, and MRI cella turcica was not indicated. Unfortunately, his doctor is insisting that he is a case of growth hormone deficiency. He decided to start growth hormone subcutaneous injection 3 times per week and to do a monthly follow-up for this boy, weight, height, basal growth hormone, and IGF-1. The child growth velocity did not improve. What are the pitfalls in the treatment? What do you think? What are the mistakes that the doctor did? Yes. Very good. First of all, growth hormone is not indicated because he relied on the basal and the child is not short. Growth hormone is never given 3 times a week. It should be given 7 times a week, every day. The body should see the growth hormone every day. Monthly follow-up of weight and height is not needed. It's done every 3 months. He will not grow in 1 month. We do not need to measure growth hormone. We just rely on the oxological data. And of course, we do not measure IGF-1 every month when we give growth hormone. We do the IGF-1 every 6 to 12 months just to make sure that it's the normal range for the dose of the child, okay? The second case is this boy, a 14-year-old boy. Parents think he's shorter than his peers. His height is -2.7. Look at the mid-parental height, +1.4. Growth velocity, 3.7 centimeters a year. He is in Tanner stage 1, although he is 14 years. Everything is normal. The father gave history that he was short and had delayed puberty and then catched up his height without treatment. This is the chart. He was normal at birth. He started to be a short child and more deceleration occurred at the time of puberty. He's plateauing his height, as you see. Let me ask you, is the child really short? -2.7. Yes. Does he fall within his parental height range or shorter than his parental range? He is shorter. Is his growth velocity okay? No. Does he have delayed puberty? He is 14. Yes, the definition of delayed puberty in boys, if you catch 14, failure of secondary sexual character at that time is defined as delayed puberty. So this was the investigation. CBC revealed microcytic hyperchromic anemia, insufficient vitamin D, basal growth hormone was low, the bone age is 10.5 and the boy is 14. His height age is 10.5, MRI cella turcica was normal in that boy. His doctor diagnosed him as growth hormone deficiency, and let me ask you, does he have growth hormone deficiency and why? The same question, which is very important to me. Of course, we do not rely on basal growth hormone. Do you think he has delayed bone age? Yes, we said more than 1 year difference is a delay. Was MRI sella turcica indicated in such a boy? No, we do not need, okay? Any diagnostic clue? Look at the bone age, it's delayed. The bone age is 10 and a half, and the height age is 10 and a half as well. What's the diagnosis? What do you think? Constitutional delay in growth and puberty. Does this child need growth hormone? No, he is not growth hormone deficient from the beginning. So the pitfalls in that child are basal growth hormone, again and again, I will continue to repeat, it's not reliable in diagnosing growth hormone deficiency. If you are not sure, do growth hormone stimulation test. Bone age is delayed and it is exactly equal to the height age, and this is diagnostic of constitutional delay in growth and puberty. In familial short stature, the bone age is not delayed at all, okay? MRI sella turcica is not indicated in such a case. Now, the doctor gave him subcutaneous injection growth hormone dose, 3-monthly follow-up, and the child did not improve, and the patient is still complaining of short stature and delayed puberty. The boy was referred to a pediatric endocrinologist. What are the pitfalls in the treatment here? What did the doctor do? Or what did he miss? Puberty, yes. Okay. Growth hormone was started before doing growth hormone provocation test. Patients with constitutional delay in growth and puberty need just reassurance and correction of vitamin and mineral deficiency and nutritional support. This is what the boy needs. And if he is still growing slowly, we give a very low dose of sex steroid to initiate the growth spurt and to start puberty, and he will catch up normally. So he doesn't need growth hormone, he doesn't need MRI sella turcica. This is what we did. We gave testosterone, he started the growth spurt, and as you see, he grew nicely, very well, and he reached very good height at the end. The third case is an 8-year-old boy. He presented with short stature and failure to gain weight. Take care. This time the boy has got failure to gain weight as well. Not only height, recurrent bloody diarrhea, history of blood transfusion. The BMI SDS is very low. The height is minus 3.8. His mid-parental height is minus 0.4. Growth velocity is 3 centimeters per year. Now, he was normal at the beginning, and then, as you see, he started secondary growth failure. He plateaued his height. And look at the weight, he was fine. And then he started to plateau his weight and recently losing weight. So we have a child both losing weight and height, okay? Let me ask you, is the child really short? He is minus 3.8 standard deviation. Yes, he is short. Does he fall within his parental height range? He is minus 4, his parents are minus 0.4. Or is he shorter than his parental range? Shorter. Is his growth velocity nice? No. Does he need to be fully investigated? Of course. Okay. The child had investigation, CBC, severe microcytic hypochromic anemia, a very high ESR, thyroid function normal, basal growth hormone low, IGF-1 low, bone age 6.5 and the child is 8. Does he fit with an endocrinal disease? No. The endocrinal disease does not affect the weight. It will not raise the ESR. It will not cause bloody diarrhea, okay? So, does he have growth hormone deficiency? Very unlikely. I don't think so. It's far away from this. Does he have delayed bone age? The bone age is 6.5. Yes, he has. More than 1 year he has, but not as bad as endocrinal disease. There's only 1.5 years difference. In endocrine disease, it's very much delayed. Any diagnostic clue here? What do you think? Any clue in this slide that could help us to go? Yes, ESR, severe anemia. The hemoglobin is 7.5, okay, in addition to delayed bone age. Does he need growth hormone at this stage, do you think? Never. So the pitfalls here are, this case needs to be evaluated for undernutrition and inflammatory bowel disease. And some of them come to us because of short stature, but this is not the case. In endocrine disease, the weight is normal and sometimes overweight. They never lose weight. Low IGF-1 can occur in chronic undernutrition, so it's not diagnostic of endocrinal disease. Basal growth hormone, again and again, it's of no value in diagnosing growth hormone deficiency. The presence of anemia, blood transfusion, indicates a chronic illness and not endocrine disease. High ESR, bloody diarrhea goes with inflammatory bowel disease. So any other suggested investigations you'd like to do for this boy? Yes. This is the basic stool analysis, occult blood, and most important, زي ما الدكتور عادل قال, endoscopy and biopsy. Of course, this is the most important. And the doctor did not do all this. He just gave him growth hormone for 6 months, subcutaneous, and follow-up. The boy did not improve. And there are pitfalls in the treatment. What's the only pitfall that occurred in that boy in the treatment? What's the mistake of the doctor here? He gave him growth hormone and he did not try to investigate and treat the cause of treatment. If he continues giving him for the rest of his life, he will not increase. My fourth case is this girl, 13.2-year-old, came to the outpatient clinic with short stature. Her height SDS -5, mid-parental height -0.7, growth velocity 2 centimeters per year, and she is in Tanner stage 1. This is her growth chart, short since birth, infancy, childhood, and adolescence. Okay, she's always short from the beginning till now. So, is the girl really short? She's -5 standard deviation? Of course. Does she fall within her parental height range? No, she's much shorter than her parents. Is her growth velocity okay? No. Does she have delayed puberty? She's 13.2, no signs of secondary sexual. Yes, she has, because the definition of delayed puberty in girls is lack of secondary sexual characters by the age of 13. Does she need to be fully investigated? Of course, yes. The baseline investigations were normal thyroid, normal peak growth hormone. She's lucky, her doctor did a growth hormone stimulation test this time. It's low. Celiac screening negative, the bone age is 10.6, and the chronological age is 13.2. What are the missing investigations here? Excellent. Yes, of course. We said we must do a karyotype in any short girl, even if she's not dysmorphic. Do an echo to exclude cardiac anomaly, ultrasound, look at the uterus, ovaries, renal anomalies, fasting insulin, glucose, lipid profile, and others. And this is her karyotype. She's a 45X Turner syndrome, and she had a horseshoe kidney, as you see here. Her doctor did not diagnose her as Turner syndrome. He just diagnosed her as growth hormone deficiency because he did not do a karyotype. He gave her growth hormone injection and she did not improve. And the mother is still complaining that she has delayed puberty. What are the pitfalls in the treatment and follow-up here? Yes. Yes, excellent. She must take sex steroid. First of all, she was given growth hormone in the growth hormone deficiency dose, and this is useless. In Turner syndrome, you need very much higher doses of growth hormone because they have growth hormone resistance. You must increase the dose, otherwise they will not respond. So it's important to diagnose a Turner, not a growth hormone deficiency case. Her doctor did not investigate her pubertal status. Now, let me ask you, does pubertal status have an impact on height during adolescence? Yes or no? Who says yes? Does puberty affect the height? Yes, a very big yes. Yes, because to achieve the adolescent growth spurt, we need a synergistic effect of sex steroids and growth hormone working together. And this occurs at the age of 11.5 to 12 in girls and 13.5 to 14 in boys. So if you do not have sex steroid, you will not achieve the growth spurt, even if the growth hormone is normal. The last here is a 9-year-old boy. He had slowing of growth 6 months duration. His height is -2.5 SD. His mid-parental height is +0.1. His growth velocity is 3.8 centimeters a year. He developed squint, deteriorated vision, recurrent headache, projectile vomiting, and a clear deterioration in his school performance. This is the child. He was completely normal. He was very nice. And then secondary growth failure occurred 5 months ago. Always respect secondary growth failure. It's always hiding a serious problem. It's very important, okay? Let me ask you, is the child really short? Yes. -2.5 SD. He is short. He's not very short because it seems that the condition is recent, but he is short. Okay, does he fall within his parental height range or shorter? He is shorter. Is his growth velocity fine? 3.8 centimeters a year? No, the growth velocity is normally 4.5 centimeters a year. Does he need to be fully investigated? Definitely. Okay. His baseline investigation revealed some anemia, low growth hormone by insulin and clonidine. The bone age is 7.5. Does he have growth hormone deficiency? Yes, he has. The growth hormone is low by 2 tests, okay? It's less than 7 by 2 tests. Does he have delayed bone age? Yes, he has. We said 1 year difference is considered delayed. Are there any missing important investigations that we need to do? Yes, of course. Okay, so remember, secondary growth failure should be fully investigated. Don't never ignore secondary growth failure. It's much more dangerous. More than one pituitary hormone defect warrants checking the rest of pituitary hormones, even if the child does not complain. Thyroid function should be assessed before performing growth hormone stimulation test, and the doctor did not do it. Any case of panhypopituitarism must perform MRI cella tosica, even in the absence of neurological signs, okay? So what the doctor did is that he did not do all this, he just started growth hormone. And the boy did not improve. and he is still complaining of headache and lack of concentration. The boy was referred to a pediatric endocrinologist, and this is what the pediatric endo found. He found a low T4, low TSH. This is central hypothyroidism, low cortisol and ACTH, central hypoadrenalism, and the rest were normal. As you said recently, yes, MRI cell revealed a very big cystic craniopharyngioma. Look at the catastrophe that would have happened. And the pitfalls here, growth hormone was started even before surgical resection and diagnosis of craniopharyngioma. Look how the pitfall could be dangerous. And growth hormone was started before giving treatment for hypothyroidism and hypoadrenalism, which is, again, a very dangerous thing. And here, the tumor was resected and hormone replacement was given, and the child is doing very nice. He's very well now, and the tumor did not affect him anymore. And finally, I think that in dealing with short stature, it's very important not only to diagnose and treat correctly, but to avoid the pitfalls. I showed you how if you do a pitfall, we could lose a lot. We could even lose the patient himself. It's very important to avoid the pitfalls, to see the happy faces of those children. And I always like to end with this in any talk of short stature. مش مشكلة. I like this slide. I think that better growth changes the future. We have a lot of children refusing to go to school because they are short. They are brilliant, but they don't want to participate in any activity. They fail to go to the sports team, although they are talented, because they feel short. Short stature is not always fatal, but I think it's a very important thing to diagnose and to deal with early. Thank you very much for your attention.
كل الشكر للدكتورة رشا على المحاضرة الممتعة اللي ما فيش فيها ولا كلمة عربي، بس كلنا فاهمينها. ما شاء الله ما شاء الله. شكرا.